So I find it very useful to come up with what is called a spot diagnosis or a 5-second diagnosis. And I usually ask myself whether after looking at the images, I ask myself whether I think the lesion is inflammatory or neoplastic. Then I decide which are the ideal biopsy sites, or shall I do only one biopsy or two biopsies on two different skin lesions. So I will only also touch on some facial pigmentary disorders, which is very commonly encountered in our practice, like melasma, facial acanthosis nigricans, etc. And I'll be discussing some interesting cases, a few benign tumors, which will not be discussed by Jasmin and our other speaker. So for the dermoscopy procedure, hygiene is, I think, a primary concern. And some publications, some articles have been published already answering the question, is there a possibility of cross-infections when using the dermatoscope? And interestingly, HPV DNA is detected on a lens prior to examination, especially after a plantar wart examination. And it is also detected even after using cleansing wipes. And the following serotypes have been identified as transmissible. And now some studies also show cross-contamination with staph micrococcus and Corynebacterium. So how do we prevent cross-infections? So basically, in my practice, I use alcohol-based gels or chlorhexidine gluconate 5%.
Biopsy results.
And I usually...
So these are basal cell pictures taken from a local Filipino study here. So again, you can see the dermoscopic criteria for basal cell are absence of the reticulated pigment network, which we only see in melanocytic lesions usually, the presence of arborizing blood vessels, which are these tree-like branching blood vessels, 52% sensitivity, and short fine telangiectasia you may also see. The large blue-gray ovoid nests, which correlate to these nests of basaloid cells, as well as multiple blue-gray globules, sensitivity of about 60 and 38%. The leaf-like and the spoke wheel areas here are more related to superficial basal cells. So I would recommend that if you do a biopsy, do it on the blue-gray ovoid nest areas, okay? Try to avoid the ulcerated and small erosion areas, but those are also high dermoscopic criteria sensitivity. And Johan also talked about shiny white streaks and concentric structures, which are newer criteria for basal cells. Now, let me talk to you about precision biopsy with dermoscopy, okay? So in the US, in this study done abroad, they used both clinical dermoscopic and RCM, reflectance confocal microscopy, which I don't do. So I will not be able to explain to you RCM, okay? Just dermoscopy. So they use paper rings or paper stickers because paper stickers, they cover up the RCM. So the RCM person can just focus on the area of interest, okay? So just by using this precision biopsy, they achieve tissue conservation in about 100% of these patients. So let's take a look at this one. So this patient has a lesion behind the ear. Dermoscopy shows these dark blue-gray ovoid nests here, some micro-ulceration areas here, okay? And then some globules here and here, as well as telangiectasia here for this basal cell.
I suggest that to all the residents and the younger consultants to use your dermoscope in most of the cases that you see, especially in some rare cases in which the dermoscopic findings have not yet been defined. And when you take photos, you just don't take one picture, you take many images and make sure you store them in a reliable archive or a file. So I think it is best that we can come up with an atlas or a book or a repository of images, even if online. I think that's the project of our dermoscopy group. That will be the project of Aruni.
Okay, from Dr. Jasmin Jamora, do you have any final words?
Yeah.